Good afternoon. My name is Scott Mash, and I'd like to welcome you to the 2015-2017 Meaningful Use Final Rule webinar. Today I will be joined by my good partner in crime, Cathy Costello. Just a few house cleaning items. Every attendee is auto-muted upon joining. This is done to eliminate background noise. As we go along and you have questions, please at that time enter your question into the integrated question box. You'll find that either at the right-hand side of your screen or at the top of your screen within the GoToMeeting app. If you can't find the question box, but you can find the chat, feel free to enter it there. At the end, Cathy and I will answer every single question. Also, a heads up, we will go longer than an hour. Our last couple webinars went over 10 or 15 minutes, so just want to give everybody a heads up so you can plan accordingly. I am going to turn it over to Miss Cathy and we'll get started.
Hey everyone, thanks for joining us this afternoon. This is our, I think, third go-round of this rule. I just want to thank all of you who may be in attendance who actually participated in putting together comments for this. You'll see as we go through the webinar that quite a high percentage of the comments we sent in on behalf of the state were accepted. So that's always good information to know. The other thing that I'd like to point out is in case you have other people you work with who have attended one of our previous webinars on this, we have expanded this to include some more information on clinical quality reporting, and we have also updated the cheat sheet that we will send to you along with the presentation at the end of the show. So with that, Scott, what am I doing here? Okay, there we go. Just so you're aware, we are only going to cover the 2015 to 2017 portion of the regs. And the reason this is significant is the regs flowed together with the stage 3 regs, and we'll talk about that in a minute. But what we're planning on doing is to break up the presentation. We wanted to get everyone started on what to do for 2015 before we got you into stage 3 stuff. So this is our last scheduled 2015 to 2017 presentation. We'll start the stage 3 education sessions at the end of next week. And when Medicaid in the Ohio Department of Health are ready with information on Ohio, specific information on attestation, we will schedule at least one webinar with them also. Okay, let's talk about what we're actually seeing in the rules. This rule, all 1,220 some pages of the 2 rules were released a week ago, and basically you've gone from 3 separate rules to 2 rules, and the areas covered are 2015 and 2016. Then 2017 is considered a transitional year, and 2018 stage 3, and that's in one big rule now, like 700 some pages. The certification rule, which is a companion piece to stage 3, was released at the same time, and that is the rule that sets the criteria for what is going to be known next year as 2015 edition cert. So that is going to be your upgrade for next year. The timeline for these rules is the big rule for the policy for 2015 and stage 3 becomes effective after 60 days. And the official publication date is October the 16th, so the official date of its effectiveness is December 15th. However, let me say that unlike the stage 3 portion of the regs, the 2015, 2016, 2017 portion of the regs are final. And this is the first time, I have to be honest with you, this is crazy, crazy, crazy. For people who follow federal regulation, it's like, how creative with question marks can you be in putting out a reg? But this reg came out so that in all of its 700 pages of glory, had sections that they specifically said this is final, and that's what they said for all the 2015 to 2017 provisions. However, in the same reg, they take the stage 3 proposals, and that's just it. They make them as proposals, and they're taking that back out for comment again. So what you're seeing and what we're discussing today is final draft. What we'll talk about next week is still proposed for stage 3, and we'll still go through a second comment period. The criteria rule has a different adoption date. It was released at the same day, but it had a 90-day window until it became effective, so it will be effective January 14th. The attestation schedule, the main thing that people have been asking about is when can you attest? It is not listed in the rule, but CMS has published information stating that attestation will not begin prior to January 4th of 2016 for the 2015 reporting period. The attestation period will go till at least February 28th, although the history has been the past several years that CMS has expanded this by at least a few weeks, but that's the earliest. MPIP has not put out their guidance yet on either the regs or their attestation process. As soon as we know, we will get them in for a webinar. But just recognize if you're a hospital, it doesn't really matter to you when the Medicaid begins their attestation unless you're a children's hospital, because every other hospital has to file for Medicare before they can file for Medicaid. So the earliest you're going to be able to do either attestation is January 4th. Okay, let's look at the reporting periods. As you know, it was proposed that the hospitals get an additional quarter of reporting for 2015 reporting period. Normally, the hospitals are on a federal fiscal year reporting, which would go from October 1st of one year to September 30th of the next. In an effort to simplify the matter and to have it coincide more closely to what the physicians and EPs are doing, this is the year that CMS has chosen to shift the hospital reporting from federal fiscal year to calendar year reporting. The advantage to the hospitals is it gives you an additional 90 days or quarter to work on your measures if you are not meeting them. So your potential attestation period is anywhere from October 1st of 2014 through December 31st of 2015. The physicians and EPs will remain on exactly the same reporting timeline. You will continue to be calendar, and your calendar period will be anywhere from January 1st of 2015 until December 31st of 2015. Let's look at how that reporting period will occur. For 2015, it is what they are calling a blended stage 1 and stage 2. And if you had listened to us when we talked about the proposed rules several months ago, you'll understand what is going on, and we'll be covering this in a few slides. But basically, CMS is contracting down the number of measures that you actually attest to. They look closer to stage 2 than they do to stage 1, but they still call it a blended measure. So this is one unified set of reporting measures with exclusions and alternate measures for what would have been stage 1 providers during 2015. The reporting period is any 90 days. I have to stress that again. You know what a mess 2014 was because everyone only had 4 opportunities to begin attestation. Attestation had to be by quarter. I think CMS learned from that lesson because they lost a lot of people who weren't meeting it right at the quarter. And so this year, it is any 90 days of your choosing will be your attestation period. In 2016, this is one thing that had been put in as proposal in a lot of the regs, asking CMS to extend all the attestation periods through stage 3 to 90-day reporting periods, but they did decline to do that. So in 2016, you are working with the same set of regs slightly different exclusions, but same set of regs. And but it will be for a full calendar year. So please make note of that, because things that you need to have, the functionalities that you need to have an effect in 2016, you need to be working on right now so you have it ready by January 1st. Now, 2017, this is again an interesting thing that is kind of, it's like CMS's evolution about how to make this program more palatable and to get their aims achieved. Because 2017, in the proposed rule, CMS could not decide how they were going to handle 2017, whether they were going to require everyone to report in the 2015 measures, or if they were going to allow people to attest for stage 3. So the way they came down on 2017 is you can attest to stage 3 if you want, and if your vendor is ready, you can do stage 3 attestation. As a reward for moving ahead with stage 3 that quickly, CMS is going to allow you to attest for only 90-day period in 2017 if you are doing stage 3. If you are back on the 2015-2016 measures, the blended stage 2, you will be doing 365 days reporting. Excuse me. The way the measures look, this is very close to the way it was proposed, is we will be doing, CMS does away with core and menu measures. From here on out, everyone will be attesting to the same set of measures. For the hospitals, it will be 9 measures. For the EPs, 9 measures plus 2 public health. For the hospitals, 8 measures plus 3 public health. As we said, all reporting will be 90 days. CQM period does not need to coincide with the meaningful use 90 days. It can be any 90-day period at the minimum. Okay, with that, I'm going to turn it over to Scott. Get a little drink of water while he's running you through some of the changes here. You think we've done this enough talking for today. But anyway, let me turn it over to Scott here.
All right, just a reminder, if you do have questions as we go along, enter them into your question box. We'll answer them at the end. There are, as in the proposed rule, a number of measures have been removed from the attestation process. That list has not changed. You know, your demographics, vitals, anything that appears on this list, you do not enter as part of attestation. The EHR vendors must keep the means to produce the reports for these measures so that you can keep monitoring. This was done to lower the reporting burden and to allow providers to focus on advancing towards stage 3. Again, we recommend strongly that you keep an eye on these measures, because a drop in your vitals, smoking, or any of these measures will coincide with a drop in other meaningful use measures and with your CQMs and your PQRS initiatives. So keep an eye on them. Now, as Cathy shared, they've kind of done away with the core and menu structure, and they're modeling the 2015-2017 rule on what you're going to see in stage 3, where we have 10 objective groups. Within these objective groups, there are multiple measures. Now, one of the objective groups, objective 9, EP secure messaging, only applies to physicians, doesn't apply to hospitals.
Okay, and the thing you want to notice at these is you'll see some of them are titled exactly the same as they appeared in the proposed rule and what you've attested to. In others, they've changed it so they're categories of policy that CMS is trying to move towards. For example, the health information exchange measure is not renamed to have it apply only to health information exchanges. That is the measure that talks about interoperability and transitions of care. So that's why you'll see different titles here, is there to demonstrate by CMS that they are meeting certain policy measures that have been set by Congress.
And also you'll note here that the clinical quality measure reporting, the number of CQMs you have to report has not changed. There's a little caveat to that Cathy's going to go into more detail later. And also the objective groups can really be broken in 2 categories. There's objectives supporting the clinical effectiveness and patient safety, and objectives supporting HIE and electronic exchange. That'll become more important as we progress towards stage 3. The first objective is and will always remain protect patient health information. Now, the title has been modified from protect electronic health information to protect patient health information to emphasize that HIPAA covers all types of patient records, both electronic storage and transmission, as well as the paper records. Now, with a large number of breaches and lost devices that you're reading about in the news lately, the protection of PHI is going to be the top priority for CMS, ONC, OIG, and others. And as you're probably aware, the ONC has started their remote HIPAA audits, so make sure you have everything in line. Now, this rule does take information that's been provided previously in a number of facts involving the security risk analysis and put specific language in to cover the interpretation. The rule, the reference to the OCR guidance linked to the HIPAA security rule appeared in the stage 2 rule, and the reference where the ONC and OCR security risk assessment tool is actually called out in this new MU rule.
Yeah, and this is something, keep in mind 2 things here, legally speaking. One is it was so interesting to hear CMS actually mention breaches in the rule. It's really the first time you've seen that happen. So it obviously pushes this to the top of their priority list. But the second thing is, because they specifically link to the security assessment tool, the SRA, it creates a question about whether that sets the standard for security review. I'm not saying that it does, but I am saying because that link is there, that you should be reviewing what is listed. If you're doing your own review, you should go to that tool and look to make sure you're covering the same areas that CMS and OCR have recommended. If you have someone outside doing it, they should be up to speed on this, but it really is something to keep in mind here.
Yeah, and really your security risk analysis must cover 3 major components, the technical, administrative, and physical components of security. Also keep in mind that the certified EHR technology referenced within this objective is inclusive of all the products that you use for meaningful use. So if you have your EHR vendor, you're using a third-party portal and a third-party reporting product, all of those products that comprise your meaningful use certification must be included in your security review. Now, the rule does now specify information around the reporting period with regards to the security review. Now, your documented security risk, while that really the document itself is a point in time, it is part or should be part of a larger living document that spans activities over the entire year. So if you have if you're a larger organization and you have a security team, make sure that your minutes from those meetings and your project notes and whatnot become part of your overall document, your overall security risk assessment. And also, the security assessment can take place anytime from the beginning of the reporting period through but prior to the date of attestation. So you have a very long period in which to actually complete that documented security review. Also, a separate security review is not required for each provider if you're part of a larger group or a hospital in practice. The organization can do one review that covers all the EPs, but it must be inclusive of all the EP locations, systems, and policies. We're going to move on to the Objective 2, which is clinical decision support. This really hasn't changed from what you saw in the proposed rule. Implement 5 CDS rules across that map to 4 CQMs across 3 of the CQM domains. If you don't have 4 CQMs and they map back to a high priority condition, keep in mind that this is the expanded definition of a CDS rule that ranges from pop-ups, order sets, documentation templates, clinical guidelines, the info button, and these CDS rules can be implemented at any point in the patient care that best enhances decision making for the care team. The CDS is not limited to the provider. It can present to any member of the care team such that it improves both clinical performance and the effective use of healthcare resources, and they include registration as part of the care team. You can actually have a CDS present during the reception process and count. Now, the second part of this measure is that you have drug-drug and drug-allergy interaction turned on for the entire reporting period, and generally that's done in most of the EHRs automatically. There is an alternate rule for providers that are reported to attest stage 1 in 2015. They are only required to have one CDS rule. Now, as we progress through these slides, pay close attention to those alternate rules because some of them apply in 2015, some of them apply for both years, and there's a few cases where the rule changes, the alternate rule changes from 2015 to 2016. It gets real confusing.
Now, just don't forget that one of the reasons CMS made these changes was to simplify the matter. So just make sure that everyone in your office knows that this is really simpler so that when 2015, 2016, and 2017 don't look identical, that's not our doing.
There is still the old stage 2 exclusion for physicians that write less than 100 med orders that they can be excluded from drug allergy. All right, now on to CPOE. CPOE looks just like the current stage 2 rule. It's 60% med orders, 30% laboratory orders, 30% radiology orders. Now, this is the old stage 2 definition of radiology orders and not the imaging studies that you're going to see in stage 3. With this, there is a stage 1 alternate exclusion that's modified from what was proposed. If you are a provider or a hospital that was scheduled to attest to stage 1 in 2015, you can use the stage 1 measure, which is just 30% of med orders. That also applies if following progression you were going to be stage 1 in 2016. Then you can also roll back. And this is done just because of the resources necessary to build and test CPOE for the stage 1 providers. And there's still the standard stage 2 exclusion that a provider who writes less than 100 med orders, 100 lab orders, or 100 RAD orders can exclude from that specific measure within this objective. And one thing we did see within the text and the comments and responses of the rule is that CMS does believe that CPOE functionality improves quality and safety because many of the CDS rules are built around the CPOE process. There was a lot of discussion around how to properly count orders. Now, if ordering a lab panel that's a bundle of tests that's around one order code, then that counts once. Now, if you're ordering multiple tests at the same time, but those have different order codes, those count individually. Another thing to keep in mind with CPOE is that it only focuses on how the information is captured and does not consider how it's transmitted. So there may be some cases where you're entering a CPOE for a lab, but you don't transmit that lab order electronically over to your lab system or whoever's processing your lab. That doesn't matter. It's how the information is captured. There was also within the rule a lot of discussion about who may enter a CPOE order and have it count appropriately towards that measure. Now, ideally, your physician enters CPOE, but you follow the recommendations that you'll find in FAQ 9058, which does state that an appropriately credentialed staff member performing similar services to a certified medical assistant, but with a more specific title, can count towards CPOE. And a good example is like a credentialed rad tech may be deemed appropriate for entering radiology orders. Now, the key point to this is that the final determination of who can enter CPOE and have it count is made by the provider or the organization based on the workflow and staff duties. Whatever you decide, make sure that you write a little narrative and include that in your book of evidence for an audit, just saying, you know, we allow credentialed medical assistants, rad techs, or whoever. Just make sure that you include that.
Yeah, and really they were very clear, and they've done this since stage 2, to say they do give deference to the provider as to who they decide to accept, because it has to be someone who has some level of training so they can respond, especially to the med orders, to make sure if there's any pop-ups they can handle it. But the fact of the matter is that the main thing they're interested in is not to have someone who has been hand-trained internally in the practice or the facility without any exterior training or credentialing. So keep that in mind. And a bottom line, especially on the physician side, is scribes generally are not included in CPOE unless you can show that they fall into one of these other categories. Like they could be a nurse, or they could be a pharmacist, they could be a medical assistant who acts as a scribe in the setting, but they would otherwise be able to enter for CPOE. But if they are a scribe, like a college kid who's spending a year or two before they go to grad school, that's not considered someone with adequate training.
Yeah, but do note that interns that have completed their medical training, they do count. So there's a little back and forth, a little bit specific. If you have any detailed questions, let Cathy and I know, and we'll see if we can help you out. Now, other couple points to note is that you can exclude standing orders or protocol orders for a given set of patient characteristics from your numerator and denominator. Now, you don't have to do it, but if you do decide to exclude standing or protocol orders, you can do so. All right, on to physician ERX. Again, really looks like what was proposed. 50% of all permissible prescriptions are queried for a drug formulary and transmitted electronically. A couple points to note. The term permissible prescriptions can include controlled substances in your numerator and denominator. If you do decide to do controlled substances, you have to do so universally. Again, you don't have to. That's an option. And also on the drug formulary, the drug formulary was included by CMS as a measure with originally meaningful use because it can lessen the financial burden on the patient. The patient, however, can be included in your numerator if no formulary exists to query, or if the query of the formulary returns no information. There's been a lot of talk about some of the EHRs having an onerous workflow to run the formulary, but CMS specifically states in this rule that providers can limit their efforts to performing the query to the workflow within the EHR with no other action required. So they run through the workflow. If they get nothing, boom, they're done. It counts.
Yeah, and we've dealt with sites where they actually were pulling the patient records the night before and then doing drug formulary queries the morning the patients were seen, you know, if they couldn't find anything in the EHR. And basically CMS spent a fairly lengthy discussion on the drug formularies, a couple paragraphs anyway, talking about how they recognize that the technology may not be all the way there, but they think it's a good idea, but they're balancing that against what is, they do not want a querying of drug formulary to be so onerous that it doesn't achieve any results. So basically stay within your EHR system on the drug formulary. If you don't have anything, don't worry about it, because that technology will improve, especially as you get to stage 3 standards.
And as in stage, we have the same exclusion that we've had in stage 1 and stage 2, and that if an EP who writes less than 100 prescriptions can exclude from this measure. Now there is an alternate exclusion. This applies only in 2015 and only for providers that are scheduled to attest at stage 1. It drops to the stage 1 measure of 40% of permissible prescriptions.
Yeah, but back up to in 2016, everyone's going to be at 50% if you're an EP.
Now on to the hospital ERX. Again, it looks a lot like what we saw in the proposed rule. 10% of your discharge med orders for permissible prescriptions for new and changed meds are queried and transmitted electronically. They did drop out refilled. It is now just new and changed meds. Same rules apply for the drug formulary. You do the automated or semi-automated process within your EHR and you're done in the count. There is the standard exclusion, no internal pharmacy or within 10 miles. Now, Where we did see a change, thankfully, from CMS is around the alternate exclusion.
Thanks to everyone's comments. A lot of hospitals in Ohio commented on this because they were not ready to do ERX in 2016.
Yeah, and if you remember back, what in the proposed rule, it said that hospitals at stage 1 or those at stage 2 that were not going to select the menu measure could be excluded in 2015. Well, due to all the comments they got back and, you know, the resources that it takes to implement ERX and the fact that many of the hospitals that didn't have ERX didn't have it in their proposed budget, they extended that exclusion out to 2016. So now ERX in the hospital is really not required until you hit January 1st of 2017. By all means, if you're already down the road with ERX, do it. There's a lot of benefit to it.
Yeah, and if it ends up that you're going to do stage 3 in 2017, then you really are looking at a 90-day period as opposed to a year. But Scott's correct, absolutely, that you want that functionality present in 2016 so you can get your workflow in order and make sure that everything's going okay so you can get it open for 2017.
And again, note, as with the the physician measure, this is permissible prescriptions. So again, hospitals can include the electronic prescribing of controlled substances. Our next objective is health information exchange. Now, this was originally titled Summary of Care in the proposed rule. And think of health information exchange kind of, it's the verb, it's the exchanging of data. It's not that you must use an HIE for this measure. Yeah. The objective is that for patients who are transitioned to another setting of care, the provider sends the transition of care where they generate the CCDA within the EHR, and then they send it electronically for 10% of the patients referred. Thinking back to the current stage 2 regulation, this was summary of care was a 3-part measure. The first part was printed, the second part was the electronic, and the third part was a test with an unlike EHR. Well, 1 and 3 go away. You're not tracking the printing. You don't have to perform the test with an unlike EHR.
Yeah, the one thing you need to keep in mind here, and we as a state generally looked at this, and I think most people did nationally in 2014, to meet this measure, people, for the most part, use direct email, the HIPAA secure email. To do that, as your receiving party came up on email, you could send it out and get credited for transition of care by sending it. It wasn't a question of did the person on the other end open it or use it. So that was one way you could meet it. But now, in this way existed in 2014 also, but not too many people were doing it, and in Ohio we weren't ready for it. The second way to meet a transition of care is to post to the community health record, so the HIE. When you post a CCDA to the HIE, what that means is it's available for any subsequently treating provider to draw down from the cloud and use that document. The difference here is when you're tracking the measure, when you're sending direct email, you get credit upon sending it. With the community health record, where there's a query function, you only get credit when the receiving party queries and draws down that report. And so that's the difference here, and you need to keep that in mind as more functionality and interoperability gets added to the structure in Ohio. You may end up doing both, and I don't think that'll be difficult to meet the 10%, but just keep in mind there are different ways of meeting this measure.
And I would recommend doing it both ways. If you are not actively posting the CCDAs to the CliniSync Health Information Exchange, and you are interested in doing so, let us know. But also, back to the measure there, the language behind the scene was simplified a bit in that the CCDA is generated by the EHR and transmitted electronically, and they use the term transmitted electronically and avoid using the term direct to allow for flexibility within the transmission method. And again, this is done to allow for innovation and future health information exchange and developments. There was a lot of comments around the lack of participation by some providers, which made it difficult for others to reach the threshold. But this is, CMS stated that that's why this threshold is held low at 10%, is to allow for those other providers who haven't gotten on board yet. And you can also now count a transition of care between providers under the same tax ID and using the same EHR, so long as the sending provider goes through the process of generating the CCDA and sending it. Now, this is a change from the guidance that we've had in the past. If you do want to count those, test your EHR and make sure it will count them. Some organizations, it may not make sense to do that. If you have questions, let us know. Now, again, as Cathy stated, that the push to the HIE cloud does not count as a transition of care until that patient is queried by another provider.
Yeah, let's look at what constitutes a CCDA for purposes of this. The fields are the same ones that were available in stage 2. You notice here that CMS is really emphasizing in the regs the words interoperability and the concept of interoperability, which goes to their interoperability roadmap also. But the reason I'm pointing this out is this was the number one reason CMS was criticized by Congress, is that they felt that there was not enough effort being devoted to interoperability. Whether or not there was a recognition on Congress's part that the development in less than 2 years' time of almost 1 million email addresses nationally for the HIPAA Secure Email Direct System, I'm not sure. I'm not sure how they're defining interoperability, but CMS really took this concept and ran with it in this provision right here. So you see the various parts of the CCDA are listed as they were at stage 2, but Scott can explain to you the difference in stage, not in this year.
Yeah, one thing to note is in the required fields that every CCDA must contain the problem list, med list, and med allergy list. Those fields cannot be blank, and they must contain the most recent information. The rest of the fields are to be populated if the information is available at the time the CCDA is sent. Now, there's more. They included some more flexibility that we were kind of expecting to see in stage 3, but they're allowing it now in that you can limit.
If your vendor can do it.
Right. Again, you're going to be. It may be a challenge for your vendor to do this at this point, but information in the CCDA can be limited to what is deemed clinically relevant. Think of it this way: if you have a patient who's admitted to the hospital. They're getting those hourly blood gases. Currently, those are included in the CCDA for the discharge instructions that are sent out of your system, but they are of no clinical relevance once that patient walks out the door. Now you have the flexibility to include only the lab results that best represent the patient upon their admission, and also include their abnormals or whatnot. You have to have the ability to send all the lab results. You just necessarily don't have to do so. Now, there is some caveat language in the rule in that if the receiving provider requests all the labs, you got to send them, or if the patient requests it, then you got to send them. So again, there is a transition to including only what is deemed clinically relevant. Now, on to Objective 6, which is patient-specific ed, no change really from what was proposed. It's 10% of the patients seen or discharged are provided with education material identified by the certified EHR. The only exclusion is physicians who have no visits during the reporting period. And again, there is an alternate, the same as we saw in the proposed rule. In stage 1, providers or hospitals can be excluded.
Only for 2015 now.
Yeah, this is only for 2015. Now, the CERT does specify that the drivers for identifying the education within the EHR are the problems, allergies, and meds. And keep in mind that the EHR identifies the educational material, but the provider should give that material to the patient in the format most useful to that specific patient, whether it's printed, whether it's pushed to the portal, or they're just given a link. A provider can give patient education materials other than what's identified in the EHR, but you don't count that in your numerator and denominator. This section of the rule does specifically call out FAQ 8231, which talks about timing with some of the measures. Now, the educational material doesn't necessarily need to be provided during the encounter or necessarily at the point of discharge. The rule states that the patient had to have a visit or an inpatient stay during the reporting period and was provided with educational material, but those two events don't necessarily need to occur at the same time. But if educational materials are provided, they can only be counted if they are within the calendar year outside of that reporting period. A little confusing, but now with MedRec is still one of those things that a provider should be doing anytime that a patient's in front of them. The measure still is at the 50% of the transitions of care into the practice or admitted facility. You perform a MedRec. The exclusion is that a provider who was not the recipient of any transitions care during the reporting period, and there's still the stage 1 alternate, 2015 only, that you can be excluded. And again, as we say every time, do a MedRec every time because that feeds into your CPHIMSS and some other measures. Now there's a lot of discussion about when the MedRec must be performed within the EHR.
Yeah, notice we quoted CMS straight out of the reg because that as a policy matter, there's a difference here between what you're required to do and what CMS as a policy matter considers best practice.
Right. Yeah, and again, the quote just says do it every time. But there are different kind of forms of MedRec and triggers, whether it's an automated inclusion, whether you're looking at paper records, whether you're discussing it with a patient at intake or discharge, or consulting with another provider. Those are triggers for your MedRec. Make sure your providers and staff are checking the box or doing the workflow, whether there are any changes, no changes, or whatever. We always say MedRec includes both new patients and patients where a summary care record is provided. You can exclude MedRec in cases where there are no face-to-face visits, like let's say you're doing an EKG read, and so you can exclude that from the MedRec measure. But if you do decide to exclude those types of visits from MedRec, then you must also exclude them from all other applicable meaningful use measures. Now again, your MedRec can be a simple review of the med list with a checkbox in your EHR. We strongly recommend that you continually communicate with your EHR vendors to improve this workflow so it can be really, really easy and efficient for the staff.
Make sure your people are checking that even if there are no meds listed or the meds that were listed were correct and there were no changes necessary, because to capture it for credit for MedRec, you have to have all 3 cases: change meds, no meds, or no change in meds.
And with that, back to Ms. Cathy.
Okay, patient electronic access, better known as the patient portal. And one of the measures that was most problematic for people last year in 2014 as you began your new use of this measure. Basically, the measure is divided into 2 parts. The first part is access to the portal. The second part is view, download, or transmit information from the portal. Basically, in 2015, and we'll look at the 2015, 2016, 2017 here in a minute, because CMS, this is one of those areas where they did not stay with what was proposed. And when we had talked about this at the time the rule was proposed, that was one of the most organized vocal groups in opposition to any section of the rule had to do with patient advocates who felt that providers should be required to have more patients access their portal. And so what you see here is CMS kind of bifurcates how they're handling this rule or this measure, and you end up with different standards for each one of the next 3 years. For the access part of the measure, the first part of the measure, it will remain the same across all 3 years, 2015, 16, and 17. And that will be the one that you're used to working with. 50% of all patients have access in the EP setting within 4 business days of availability. And that access is determined in 2 ways. Does the information push to the portal. So are your labs pushing to the portal? Are your summaries pushing to the portal? The second part is, have you given the patient access? And this is something CMS acknowledges in the rule, that different vendors handle the calculation of access differently. But they reiterated the fact that access is given where you give the patient all the information they would need to access the portal, whether they choose to do so or not, but that they would then be able to do it at a later point in time. So your vendor may capture the access portion of that measure only if the patient activates by going in and setting it up through their email address. So even if the vendor's capturing the email address, we know several vendors that will not give you credit for this unless the patient then goes in and activates the portal. That is not the full definition of access. Access is when you, as a practice or as a hospital, give that patient all the tools that they need to get to it, whether or not they give you an email address or whether they activate the email address. If they don't, you can always either create a dummy email address or calculate that separately. The second part of the measure, the view, download, and transmit, is the one where you see change. Because in 2015 and 2016, you only need to have one patient view or go in and view their records in the portal or download them. And it's one of the three, view, download, or transmit. So it's any one of those three. You just need to get one patient to do it. There is an alternate exclusion in 2015 only for stage 1, and that is you don't need the one patient to view it. But, you know, that's a minor part of this. For the hospitals, let me flip over. These are, again, the list of fields that are required to show when you have a summary post to the portal. For the hospitals, there is a change in what you have to do for access. As you know, in 2014, access for the hospitals was determined by the posting to the portal within 36 hours of discharge. This has been changed to put it within 36 hours of availability. But the thing is that the denominator is set by the patient's discharge, so it's not availability while the patient's still in the hospital. It's availability once the patient is discharged, and if you have, for example, lab tests that have not come back within the first 36 hours, you need to make sure that those continue to post to the portal as they become accessible to the hospital. The second part of the measure for the hospital is the same as for the physician. In 2015 and 2016, one patient needs to access the portal. In 2017, this is where we said that you had the patient advocates come in and comment on the rule, and CMS recognized that. In 2017, we are back to having to have 5% of patients accessing, view, downloading, and transmitting their records in the portal. So keep that in mind. You really only have a little bit over a year as you get into 2017 and you're back at that 5%. And one last thing for the EP side of the equation, make sure that for every single provider you can demonstrate that one patient has accessed it. It's not one patient for the practice, but one patient for each of the providers. Okay, again, here are the fields. Secure messaging. This is another one that was a patient-facing measure. And this is one that CMS has totally rewritten, and one of the reasons we think they kept the rule together with stage 3, because this is one of the places that the stage 3 measures come back in to 2015. As you know, originally you had to have 5%. This is just for the EPs, no hospital requirement here. You had to have 5% of your patients contact you via email to have this measure count for you. What they did is they backed off because this was a very difficult measure for many providers because patients were doing it. So in 2015, they said, okay, rather than having the patient contact you, we just need to see that you have the functionality to do it. So you want to have a screenshot or a report to show that that functionality is enabled. In 2016, you move up a little bit and you have to have one patient who sends you an email, but the difference here is what was proposed in stage 3. And that is, rather than the patient sending you an email, this measure is now calculated based upon the practice of the provider responding to the patient or generating an email to the patient themselves. So in 2017, you get back to the 5% level, but it's not 5% of your patients email you. It's 5% of the patients seen during the period you email with clinically relevant information. So this is not a reminder of a previously scheduled visit. Rather, it is something that it's like, have you gotten your A1C done? You've got abnormal results. Please contact the physician. Do you have questions about your refills? We see a problem with that.
Or even a message after post-visit saying, hey, how are you feeling? We just wanted to follow up and see how you're doing. That would be deemed clinically relevant.
It just can't be an administrative function. It can't be a scheduling. It can't be a billing issue.
Yeah, and it can't be a message generated by the reminder function within your EHR. I do strongly recommend that you do some testing now with your EHR to see if a provider-initiated message stream also counts towards this. Probably doesn't. Start working with your EHR vendor. Now, do keep in mind that the messages sent by the patient also count. So it's you either receive them, you respond to them, or you generate them outbound. So a lot of different ways to hit that 5%.
Yeah, okay. Let's talk public health reporting, but we are planning to do a separate webinar on this when the Department of Health is ready to talk about it. Let's just say, as late in the year as it is, that I don't think you'll see a lot of change in the public health reporting in Ohio in 2015. The changes that will be recommended will most likely be starting with 2016. But basically, the EPs have to report for 2 public health reporting measures. The hospitals need to report for 3. The difference between the final and the proposed rule is that the proposed rule had a totally new category in this area called clinical data registry. So it was the private data registry reporting. And it created all kinds of issues about how you would know if you were eligible to report, or when you could claim an exclusion and what the standards were. Well, CMS heard that, and there was a lot of their commentary on this was they recognized that the clinical data registry area was really not ready for prime time. And so they backed off on the public health reporting to basically the same scenario that you had in 2014 for stage 2, but they express it a little bit differently. So in 2015 for EPs, you have 3 potential fields that you can do public health reporting in. One is immunization, one is syndromic, and one is specialized registry reporting. This specialized registry reporting is not clinical data reporting. This is like public ODH type reporting, and we've asked for clarification whether this would include CDC reporting. But basically, if you are a physician and you are doing, let's make one comment too. For public health reporting, you do not need to be actively submitting. You need to be registered and in queue to work with either the HIE or the Department of Health for sending data to them to meet meaningful use. But the 3 areas are immunization, which was probably the most used one by most providers, syndromic, which is actually not accepted by ODH except in a few instances have they done that. That's usually due to their funding. In the specialized registry, which under the 2014 regs was cancer registry reporting. What you can do as a physician is you can register for syndromic surveillance even if our ODH chooses not to invite you in, which they may. If they invite you in, It's probably not going to be for several years and only if you're part of a larger group. But you can register and meet meaningful use. So immunization or syndromic, or take an exclusion if you're not an oncologist for cancer registry.
A couple of specifics to point out is if you are a stage 1 provider working with a stage 1 practice, what this means that you'll have to do is, in the past what you've had to do is go to the ODH website, you register, and then you submit a test message. Well, now you have to go through the stage 2 registration process. You're going to register your stage 2 intent. Also with the immunization, there was some additional language. Actually, it was released in an FAQ, but included in this text as well, and that previously, if you were live on immunization registry and you had to give an immunization within the reporting period to use that, to meet that measure. Well, now the way the rule reads is that if in your normal practice you do give immunizations, but you just don't happen to within the 90-day reporting period, you can still attest that you met the meaningful use immunization requirement.
Okay, for the hospitals, you are back to having 3 measures, which, as you know, in 2014 were immunization, syndromic, and ELR, electronic lab, reportable labs. If you're in Q, you're working with the HIE, you're working with ODH directly, you have met all 3 of those. If you're excluded out because of your size, a lot of the smaller hospitals do not do all the lab testing for this. You now specifically can take an exclusion for that. Immunization exclusion is if you don't administer immunizations. Syndromic is if, as a hospital, you do not have an emergency or urgent care department. And specialized, or ELR, you don't perform the lab test. The specialized registry, I just want to point out the one thing that CMS raised in the rule is what's called prescription drug monitoring program. In Ohio, that is called the OR system. And those of you who work in hospitals know the ED docs have to check for controlled substances before they write a prescription. And actually in the private sector, the EPs too are supposed to be doing that under Ohio law. So we've asked for clarification from the Department of Health whether or not reporting to the ORS registry would constitute a specialized registry that could be listed by either hospitals or physicians. As soon as we have information on that, as I said, we are inviting ODH to host with us a webinar about this, and we will let you know the answer to that question. But for right now, clearly cancer registry is part of it. We don't think any others are within Ohio, so you would take an exclusion. Now the last area that we're going to cover before we get into questions is just clinical quality measures, because there were a number of changes in this area. And we have expanded from what we presented last week to cover more of the information on the hospital clinical quality measure reporting, to include the information that was sent out in August in the IPPS final rule. But on the EP side, let's look at the progression. You are going to be reporting the same as you did in 2014. You will be reporting 9 CQMs across 3 domains. In 2015, you can report a 90-day period. It does not have to coincide with your meaningful use attestation period, but 90 days of CQMs. In 2016, you can either attest or submit eCQMs, electronic CQMs, but it has to be for a 1-year period. This is for EPs. In 2017, you can either attest or submit electronic CQMs, but it must be for a 1-year period, even if you're doing stage 3 and doing only 90 days for meaningful use. In 2018, everybody is on electronic quality reporting. For the hospitals, it's a little more convoluted. Let's look at the CAHs first. The CAHs are not required to go with the rest of the hospitals' kind of accelerated reporting, so they are more like the physicians in the sense that come 2018, they'll have to be doing eCQMs, but not until then. Let's look at the rest of the hospitals, though. In 2015, you'll be doing 90-day, in 2015, you'll be doing 90 days reporting for 16 measures, which is what you did in 2014. In 2016, this is where it gets a little squirrely. And this is, again, CMS's carrot and the stick approach. In 2016, if you're part of the IQR, so the inpatient quality reporting, you must submit 1/4 of electronic CQMs, and that would be either Q3 or Q4 of your choosing. The carrot part of this analysis is that rather than reporting 16 measures electronically, you only need to report 4 measures. So what they're saying is, yes, we know this is a difficult area. A lot of hospitals have problems with all their CQMs, but we still feel it's important to move ahead electronically, but you can just do 4 measures in 2016.
Now, it's also important to note that that submission of the 4 ECQMs is to the Quality Net system
right.
and not the Meaningful Use Attestation system. But when you submit it to Quality Net, it counts towards your Meaningful Use CQMs.
And if you cannot report for whatever reason an electronic version, you would attest and you would file for this extraordinary circumstances exemption, which is basically having a vendor issue, infrastructure issue. Now, in 2017, this again changes for the hospitals. In 2017, you're back to a full calendar year of reporting, even if you're doing stage 3 attestation. And you can do either attestation or electronic, even if in 2016 you did all electronic. In 2017, in 2018, well, 2017 you have to use the 2016 measures. In 2018, you must submit all your ECQMs electronically, and your system must be 2015 certified. For those of you who are Medicaid hospitals, you children hospitals, Medicaid still has the option to receive everything through attestation, and each state can set their own guidelines on that. So as soon as MPIP does that, we will let you know.
Now, the CQMs portion for the hospitals is about as clear as mud, we admit, and we're still trying to get a full understanding of it. The key is continually work to improve your CQM reporting from your EHR. Always work to try to identify if something's not mapped or if folks aren't following a workflow. Educate, educate, improve, educate.
Yeah, and we have this cheat sheet we're sending out with the slides today that has this all summarized. But the one thing about CQMs, they are going to change every single year in either the physician fee schedule rule or the IPPS rule for the hospitals. So please pay attention, even if you think you have a grasp on what they're saying now. That may change from one year to the next. So with that, I think we can head to questions.
Yeah, just real quick, if you guys are having issues with meaningful use, PQRS, we do have services where we can help you out. If you have received an audit and need assistance responding to an audit, or are worried about an audit and would like a mock audit performed, those are all services we can provide.